also get the link by referring to the Google Meets chat for this meeting. In general, participants include representation from medical societies, professional associations, hospitals, healthcare providers, consumers, and health IT vendors. MHCC staff take attendance by recording the names of participants via the Google Meets web link. If you are calling into the meeting, we ask that you please confirm your attendance. Our contact information is at the bottom of today's agenda. Thank you. So now I just want to cover some housekeeping items. This meeting is being recorded. The recording will be available on MHCC's page. Please make sure that you attend the meeting either via the web link or by dialing the phone number. Not both, as this can disturb the audio and we encourage you to use your camera if joining via web. You can mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. It's best if you mute your line until you are ready to comment to avoid any unintentional background noise. MHCC staff may mute you if there is a lot of background noise coming through. And use the chat function to send notes to all attendees. However, please note that you cannot send a chat to specific attendees with this technology. If you are having any issues with the technology, please email Justine or Nene. Their emails are listed on the agenda. You can also use the chat function and someone will assist you. MHCC staff will sequence participants who wish to speak. We understand there may be times you may want to respond immediately to a comment, so please signal the MHCC team if you would like to speak. One method is by taking a sheet of paper and folding it in half and holding it so it's visible on the screen. So please be mindful to make sure that your camera's position if you're joining by video to make sure that we can see you and the sheet of paper. MHCC staff may request certain participants to comment on occasion to ensure that there is a range of perspectives represented. A link to the materials was emailed to you yesterday, and I will include it in the Google Meets chat now if you need a copy. If you're joining by web, the materials will be displayed during the meeting, and you should see the agenda up now. I'll pause here and turn it over to David Sharp, MHCC Center Director for Health Information Technology and Innovative Care Delivery.
Okay, thank you, Ava, and good afternoon, everyone. It's great to see a lot of faces that I haven't seen in a while, and good to say hello to folks that may be new to the work that we're doing here. So you are participating in the Telehealth Policy Workgroup. This is our virtual kickoff meeting. Just a couple things to mention. We can only see so many participants on our screen. There's more than 60 folks that are engaged in this webinar. So we may not be able to see you if you wish to make a comment. So to that end, please, in addition to what Ava had asked, please feel free to let us know you have a question. You can either chat it to everyone, or you can just sort of interject where you think it's appropriate. We want to try to keep the flow moving today. You can see we have a very ambitious agenda. We don't anticipate getting through all of it today, but I would say to you that what we'd like to try to accomplish is all these agenda items within about 2 to 3 meetings at the outside. Some of the work that we anticipate could take us the longest would be the development of what we call information grids, and we'll get to that in a little bit. But they take a little bit of engagement from all of us. However, we want to keep things moving through sort of a rapid fire approach that we don't get too bogged down, and we may ask everyone to consider some activity between this meeting and the next meeting, which will help keep the pace moving forward. So joining us, as Ava mentioned, is our Executive Director, Mr. Ben Stephan. I would like to invite him to make a few remarks at this time.
Thank you, David. Members of the work group, thank you very much for joining us this afternoon. I think David covered the aspirations of the staff in terms of taking on this particular issue. that we tried to be very broad in terms of identifying potential issues, or maybe I should better say policy options and legislative reforms. But it is very likely that we're going to decide to put some of those aside as we move through the course of this meeting and the next one, based on input from the work group. So with that, I would encourage everyone to think about this as we move forward, because we believe that this attendance signals the enormous amount of interest, which is going to translate into one or more legislative proposals in 3 months. And we'd like to, if we can, build some consensus, but also recognize that many of you may want to make a run at a legislative proposal on your own and just see how it goes. We are open to collaboration, but recognize that the opportunities that have presented themselves over the last 6 months may provide some additional encouragement to this or that stakeholder group. So excited to go forward with this. And I want to recognize all of the staff, Ava, Nicole, Anene, Alana, Justine, as well as David, for being willing to put this together and really coming up with a comprehensive work plan.
Thank you, Ben. So to get started, what we want to do is to provide the work group with a general sense of the policy changes that have been implemented in response to COVID-19. Many of you clearly know what they are, but there's a mixed level of understanding. So hopefully those that have a great deal of knowledge will indulge us a bit as we try to raise the tide of awareness for everyone equally that's participating on the work group, which will ultimately lead to a much more productive conversation as we journey downstream. So my colleague, Nikki Mhcc, is going to step us through a handful of slides. Nikki. And you're muted, Nikki.
My apologies.
No worries. I think we lost the slides, by the way.
Yes, I'm going to share my screen again.
Okay.
All right. So to kick things off, as David mentioned, I'm briefly going to overview how telehealth policy has responded to COVID-19, noting some key changes that have been essential to make sure patients receive safe and uninterrupted care during this public health emergency. If you recently attended the Mhcc meeting, these slides may look familiar because David presented on a similar presentation just the other week. In terms of the public health emergency, you might recall the federal government first declared a public health emergency on January 31st this year, which has been extended every 90 days. The current one ends late October. Similarly, Governor Hogan enacted a Maryland state of emergency in March, which has been renewed every 30 days as well.
Nikki, can I pause you a moment? If the screen sharing doesn't appear to be coming through to my screen. So Ava, can you confirm you can see the slides or not?
No, I can't see the slides either.
So Nikki, do you want to proceed? Everyone has them on paper. If you wish to walk us through that and just give us an indication of what page we're on.
Yeah, and if you want to pull them up for me too, I'm not sure what's going on, but if you could pull the slides up too. I'm on slide number 2 though, it's actually page 3 of the meeting materials.
So we'll pause momentarily, but otherwise we don't want to lose much time. We'll keep moving forward and just assume that everyone will keep up with us manually. Ava, we'll give her a few moments to see how it works.
Okay. So I can still kind of lead on with the intro stuff, I was going to share the changes which have, oh, here we go.
Okay.
So you can back up one slide, Ava, and that'll be good. Thank you. Apologies on my end, not sure. Okay, so changes in telehealth policies have enabled healthcare providers to quickly pivot their operations to support ways that virtual care can minimize unnecessary exposure to the virus. This rapid acceleration of telehealth during this critical time has largely been supported by changes in reimbursement policies that had previously limited its use. In March, the nation saw about a 50% increase in telehealth visits. Moving on to the next slide, this overviews the key policy changes, some of which vary across payers. This includes temporary waivers as it relates to eligible providers and covered services, patient location, licensing, the establishment of a patient-provider relationship, and cost sharing. I'll step through each one of these in a moment, but wanted to note equally important has been making sure providers have appropriate technology to provide services remotely, which was an issue for many who had not adopted telehealth prior to COVID-19. So on the next slide includes some of the information this was addressed by OCR, and they lifted through a notification of enforcement discretion back in March, certain HIPAA restrictions as it relates to technologies that could be used for the provision of telehealth services. This includes those popular non-public facing applications like Apple FaceTime or Facebook Messenger. The OCR is not imposing sanctions or penalties for providers that use these specified technologies for telehealth that are not HIPAA compliant, provided they are used in good faith and for diagnostic purposes. So in the next slide, I'll step through each of these key policy changes I mentioned earlier. In terms of licensing, rules have been relaxed to allow providers with an active license in another state or the District of Columbia to practice telehealth in Maryland. Licensing requirements vary across states. In Maryland, a provider must be licensed in the state to treat patients in the state. Practice across state lines on the next slide, please, has allowed providers to deliver telehealth services wherever the patient is located, including their home as well as outside designated rural areas. The expansion of audio-only visits has allowed patients to continue care with providers that had not implemented telehealth. It's also allowed patients who don't have a smartphone or a computer to access care, especially those, it's made it easier for those living in rural areas without broadband internet.
And Nikki, can you remind us the slide that you're on?
Right here that Ava has on it's number 7 slide. So both the new and existing patients have had access to care for an expanded list of services that can be provided using telehealth during the public health emergency. And as I mentioned on the previous slide, some telehealth services no longer require both audio and video, allowing more visits to be conducted over the telephone. So on slide 8 here, in terms of eligible providers and covered services, this has significantly increased patients who can take advantage of telehealth. This includes non-physician provider types like licensed clinical social workers, clinical psychologists, physical therapists, among others listed here. Home health and hospice can also provide more services as appropriate. And remote patient monitoring is another area that has allowed providers to expand their capabilities, helping address challenges of delivering care in real time without putting patients or themselves at greater risk of the virus. So the next slide covers cost sharing. And if you have taken advantage of telehealth during this time, you might have experienced this yourself, because several carriers have allowed out-of-pocket costs to be waived, or in some cases reduced to some extent. typically when using an in-network provider for telehealth services. But like many other policy changes, these flexibilities are subject to certain payer requirements and timelines. Moving on to the next slide, this is in terms of wrapping things up and where do we go from here. Many are starting to think about telehealth post-COVID, and there's considerable support to make many of these telehealth policy changes permanent. This is in part due to some of the satisfaction expressed by providers and patients. A recent study found 65% of consumers plan to use telehealth more after the pandemic, and 78% said the public health crisis has shown how badly U.S. needs more telehealth options. Some payers have signaled plans to term some of these temporary waivers, such as cost-sharing flexibilities and audio-only visits. But for the most part, stakeholders feel a complete return to the prior policies is a step backwards and would have negative consequences on consumers. Discussions are ongoing to evaluate benefits and examine what policy changes should remain, which is why we have convened all of you great folks to get this conversation started today. So I'll stop here. I'm happy to answer any questions, but if not, I'll turn it back over to David.
Yeah, and as folks are thinking about what questions might come to mind, we're going to dig into the detail of where we go from here. And what we've heard, just to sort of summarize what Nikki said, is that no one believes returning to where we were a year ago this time is the appropriate pivot point. But there has been a lot of varying opinions about where we should end up once the public health emergency has concluded. As Nikki pointed out, it is ironic to think that it took a pandemic to really bring telehealth to the forefront as a modality in care delivery. We are here. It was implemented at light speed, and this is a great opportunity to hear from all of you. So please let your voices be heard today. We appreciate that. There are no good answers, bad answers, or right answers. So let me pause for a moment and again, just remind everyone we don't have a visual on all the participants. So if you have a question, please just announce yourself. And if you are dialing in, again, no, we're not seeing your name. So if you could also say who you are, that would be helpful. So let's stop for a moment and see if there are any questions on at least what Nikki has presented thus far.
Nikki, this is Ben. I know that there have been some more recent results on telehealth in the summer months. Do we have anything we can share there? Because I think there was, after a very significant uptick in utilization as we had nearly a complete shutdown, as we move to a more, what I guess now is termed a hybrid model, there were some services that returned to face-to-face and others that the tendency was that it continued to be largely delivered on telehealth. Do we have any information on more recent data in the
Not in the slide deck, but you are absolutely right. There has been several studies recently published where we saw this huge spike during the peak of the virus around that March, April, May, June timeframe, and then it's slowly tapered off. And some providers have gradually returned more and more to in-person. But there are several that are sort of thinking more broadly who sort of implemented those a temporary solution like the temporary applications permitted by OCR to get them through that initial rush, and thinking more long-term what that blend of in-person and virtual care looks like. We'll be happy to bring back more data at the next meeting, perhaps with some of those newer studies that shows sort of where telehealth visits have sort of fluctuated. We can do that.
And I can see Rebecca, so maybe I'll call on her as a first person out. So from your vantage point, perhaps you could address Ben's question a little bit from where you sit and things that you've seen at Hopkins.
could you rephrase Ben's question for me? Do I
So-
think we could go back to normal?
Yeah, it's more of a volume question. When telehealth was implemented, sort of light speed, what was the share of telehealth, and then
Oh, sure.
where's the organization have ended up now that there's
Where are we landing? Yeah, so I would say at the height of the pandemic, we got as high as 80% of the care was via telemedicine. And that includes things like radiology and testing that are kind of pandemic neutral, right? Those had to remain in person. So more than the lion's share was virtual. Then we kind of plateaued at around 30%. Right now we're between 20 and 25% virtual on the ambulatory side, and we anticipate that to remain pretty constant. We have seen some slight trending up week by week, and so we're following it closely, but we're staying between that 20 and 25%.
And it's interesting. Thank you for sharing that. And I believe Jean Ransom or Susan D'Antoni are on the line. If either one of you are able to speak, you might give us a perspective from your view of the physicians. Okay. They might not be able to speak, or they just haven't joined. Is there anyone else that might have a perspective that they wish to share?
This is Helen Hughes from Hopkins. Just to piggyback on what Rebecca said, in September, I think behavioral health was still about 80% telemedicine versus ophthalmology was less than 1%. So I think some of our specialists who are more procedurally heavy have converted mostly back to in-person, and then behavioral health and some other specialties that are less reliant have continued to do more virtual care.
Yeah, that's interesting. I believe we have Sonia Lawson from the Occupational Therapy Association. Sonia, are you available?
Yes, I'm here.
So what is your perspective on that from the therapy standpoint?
I haven't taken a poll of our therapists in the state, but I know that a lot of therapists have started using telehealth services and really find that it has been helpful. And I'm pretty sure a good cadre of them are going to continue to use that as an option, doing like a hybrid kind of version where people who are having difficulties coming in for visits can opt to have things done through telehealth. So not necessarily a required telehealth visit, but definitely an option to do it that way.
Good point. Good point. And just a couple more perspectives on that before we move on. Allison Taylor from Kaiser Permanente. Are you able to speak? Okay.
David?
Yes.
David, this is Sally Alborn from Maryland Community Health System.
Good afternoon.
Guy, how are you? I just wanted to share, along with Rebecca's comments, at the height of the onset of COVID, we were up in the 80 to 90% in terms of telehealth. We've slowly come down to around 40%, kind of hovering around 30 or 40. Behavioral health, telehealth visits went off the charts, even compared to medical visits. And that continues to be at a fairly high level. There seems to be a higher comfort zone. And I think that one of the lessons we've learned as we've tried to bring people back in for on-site visits, just even routine things, not things such as labs and stuff that need to be done in person, is a high degree of preference for telehealth visits by patients. So we've got a lot of very strong feedback. Even when we say we'll provide transportation, the patient is saying that we prefer the telehealth visits. And I won't go into the details now, but there's a whole host of reasons we've ferreted out for that. But I wanted to share that with you.
Thank you very much.
Yeah, that's a great point. I would say we did an internal survey. 88% of our patients felt it was important to very important that telemedicine continue beyond the pandemic.
Interesting. Okay.
David?
Yes, Robin.
Yeah, good afternoon. So just piggybacking on what Sally Ann said and some others, we are looking at dental, and dental, of course, is procedure-based. And therefore, there's been some work in terms of allowing providers and getting them up to speed to do telehealth. But what we found is now that they've started, that they want to retain the ability to do that. And so whether that's in a community health center or a private practice, there is a ton of interest.
Interesting. So perhaps we get perspectives from a different angle on this before we move on. Is John from Teledoc, Dr. Goldberg from Teledoc on? Okay, and then I think.
Hello. Sorry.
Go ahead.
It's Pam Pacemeyer. I know you had asked earlier for Gene, and I'm not sure whether he was getting on, but on behalf of not only the State Medical Society, but also our firm does some work with federally qualified health centers, but now I'm talking for the doctors as well. I don't want to reiterate what you've heard from everyone else, but I guess I would consistently put the physician practices have found the use of telehealth to be exceedingly helpful, useful, and are anxious to work with everyone to make sure all the positive benefits and access issues that have been realized are able to be transitioned past this public emergency.
Very good. Thank you. John Cornick, are you online?
I'm here, David.
So it might be interesting to get a perspective from a different angle on this. John is a representative from American Well. Can you give us your sense of the impact of telehealth on organizations such as yours during this pandemic?
Yeah, definitely. So quickly had to pivot from a lot of companies, a lot of hospitals, healthcare systems who were doing in-person medicine to just doing medicine from a different angle. I won't call it telemedicine because ultimately we need to get out of that saying tele in front of everything. But really the shift from in-person to scheduled visits online, and that's providing not only the services from their own providers, but also having other physician organizations have accessibility. So we saw everything from hospitals, healthcare systems, clinics, employer groups go from very low numbers to thousands of visits a day. Even in the state of New York, we're talking phone call services, EM. We were seeing thousands, and quite now that most have kind of simmered down. I wouldn't say, but really wanting to make sure that a lot of these solutions are incremented into their EMR, that making sure that customers, that patients are actually utilizing patient portals more, having that user experience be more validated within their own platform. And we just don't see it really slowing down anytime soon, even post-COVID. We don't feel that telehealth's going to go away anywhere at all. So.
Okay, that's very helpful. Thank you. So I can't resist just getting one last perspective. I hope you'll indulge me. Jim Hummer from Lawson, are you available? Okay. So he may not have joined or be unavailable at the moment. So why don't we, with that, move on in the agenda, unless anyone else has a comment to make or a suggestion. And Ben Wolf,
David?
Yes.
Hi, this is Nicole Brandt from the University of Maryland School of Pharmacy.
Good afternoon.
Good afternoon. Great to hear your voice and this program. I just wanted to convey, I got the documents and the invitation thanks to a colleague, but I just wanted to express the role of pharmacists during this pandemic via telehealth as well. And I continue to practice as a pharmacist embedded in a primary care setting where we're caring for approximately 800 to 1,000 older adults in the community. and doing a lot of telehealth, telephone with chronic disease management as pharmacists. And I continue to see pharmacists not necessarily always on these lists, but they're a very important part of the provider team with respect to helping with chronic care management, especially during transitions of care. So I just want to add that to the discussion for the future, David, if possible. And like many have mentioned already, the role of meeting our patients, especially those with maybe limited access because of transportation limitations and mobility concerns. Telemedicine, telehealth, telepharmacy, whatever term we want to use, has really helped us really meet patients where they're at. And we've learned a lot with respect to some of their resources at home too through these portals. So just want to mention that both as from a professional lens perspective as a pharmacist, but also from a patient population that I typically still see underserved in our communities, and those are older adults.
Yeah, outstanding. I think you're absolutely right on all fronts. I don't know if Jennifer Thomas from the Pharmacists Association is on with us or not, but we absolutely think that the perspective you bring to these kind of discussions is extremely valuable. So appreciate you taking the time.
David, I know Allison Taylor couldn't speak, but I think there are a couple other payers on. Maybe we could at least see if Medicaid and Carefirst had a perspective.
Yeah, definitely. I think we have
Matt too. Matt is here.
So we see Matt. So Matt, why don't you launch us off, and then if there's a representative from Carefirst, we'll go that order, and then to Ben, and we'll see if we've missed anyone at that point.
Okay. Good morning or good afternoon, guys. David, Ben, everyone else at MHCC. It's good to see all of you. I wish we were at 4160 Patterson, but here we are. I want to thank you guys for getting this together. I think, as we all know, this is certainly a very fluid situation, and payers have been adapting to an unprecedented public health crisis through the spring, and will continue to sort of pivot to whatever the public health need is during this incredible crisis. I don't think there is any payer, either on now or in the past, who would ever suggest that we're ever going back to the way it was prior to COVID-19. But there are certainly a lot of policy considerations have to be taken to find out what is appropriate to go back to post-COVID worlds. I don't know when post-COVID world's going to be, and I don't anticipate any payer kind of backing off a policy in the midst of a public health, crisis. But we are happy to be here. Thanks for including us, and I'm sure we'll have a lot to say down the road. Thanks, David.
Fantastic. We're glad you could be here. So is there someone from Carefirst on the line?
Yes, good afternoon, everyone. This is Oleg Tarkovsky from Carefirst. I'm the Director of Behavioral Health Services. Hello. We have definitely seen the demand for behavioral health, telehealth services spike as a result of COVID. And as somebody just mentioned, the proportionality of those of that demand is significantly greater than ever before. And so we're doing everything we can in our power to accommodate those requests.
Very good. Thank you. Ben Wolf.
Hold on one second. It's Debbie. I'm sorry. Can you hear me?
We can hear you now.
So I would just, hi everybody. So one thing I would just, as an overarching statement, I could tell you for myself, and I've been IMing with a number of people from different companies. There's a number of organizations that don't allow the platform of Google Meet. And so none of us are able to get on to this call. And I think, except for doing it by phone, which is really not the greatest method. So I'm wondering, selfishly, I'm asking, and for others as well, whether it's possible that we can find another platform so we can all participate. I think it'd just be easier. That's my just overarching statement, because I don't think I'm going to have a chance to talk again.
So we'll look at that. We, until recently, couldn't use Zoom, so clearly the most popular platform the state of Maryland couldn't accommodate. We now can do that. The only disadvantage is that all of the staff are really familiar with Meets. but I think we'll take that into consideration. I didn't want to, before we get back to the issues at hand, want to thank Matt for his call out to the beauty and splendor of the Maryland Healthcare Commission's world headquarters on Patterson Avenue. But we'll also consider perhaps in the not too distant future, perhaps hybrid type approaches in which some people socially distanced and wearing masks can attend that beautiful facility in person. So, but we will look at Zoom. I think that's probably the most popular candidate on the market today.
Yeah, because I don't think I was aware that the challenges, Deb, that you've mentioned, I simply wasn't aware that they existed, actually.
Yeah, no, I'm not the only one. Carefirst is not the only one. So I just think we're all struggling, which is similar to what's happening in the whole world of telehealth, right? We're all trying to figure it out. In a way, this is our foray into the different type of world than actual face-to-face visits. But it is a struggle, and it is not as productive, at least for me, and I assume for others, if we can't actually see each other, see the documents, and participate fully. So that's just would be a great future endeavor if we can think of some way that we can all get on.
Yeah, message.
Thanks. And as the Carefirst data, we're still pulling things. We don't have anything to share today because obviously we have to look at it. We've heard from a number of different groups today, right? You've got the pharmacy benefits, you have behavioral health, and then hospitals and providers. And so we need to really cull through the data for each type of provider group because they're all going to be different. And we'll be happy to share information as we go forward, but we really don't have anything of substance to share today.
Okay, but we'll come back to you knowing that you're online, and hopefully you'll be able to participate as we go forward for the rest of the afternoon here. But thank you for joining us, and sorry for the inconvenience for anyone who's joining by phone that would have preferred a video approach. Ben Wolf, anything you can add here?
Yeah, hi, David. Hi, everyone. Nice to see all the MHCC folks again and everyone else. I'm Ben Wolf. I'm Director of Provider Compliance for Medicaid Office of Provider Services. And we might have a couple other folks from Medicaid on as well. I'm not sure if anyone from Innovation Research and Development or the Leadership's Office is on, but I'll just give a quick rundown of the background on Medicaid's policy changes during COVID. One of the governors and secretaries' first orders back in March, seems like a long time ago now, was to expand the telehealth program to allow the home as originating site, which means allowing Medicaid to reimburse for services when the patient is at home as opposed to a clinical site. That was done very early on, and Medicaid certainly intends to continue to allow that the patient's home or other secure location to be an allowable originating site after the conclusion of the public health emergency. There's, as you can imagine, a lot of details to work out with respect to specific programs and what services should be included, what services might not be suitable for telehealth at the home, but the agency's intent is to go forward with making that a permanent regulation change, which we have the authority to do at the state level. Just to remind everyone, Medicaid is a jointly state and federally funded program subject to both state and federal rules. Some things we have the authority to change through state policy and state plan amendments. Other things are reliant on federal action. An example of that would be audio-only services, which are temporarily allowable under the federal public health emergency. When that emergency expires, we, as of now, would expect audio-only to no longer be reimbursable unless we receive additional guidance to the contrary from CMS. But there's a host of other types of policy changes that affect more specific programs, EPSDT, or early screening and prevention programs for children. We've recently expanded our waiver to allow clinic services to be reimbursed when neither the practitioner nor patient is located in the clinic. So we're continuing to, it started in March, and it's pretty much been a steady barrage of policy changes and temporary guidance ever since. I can't go through them now, and probably couldn't even if we had time, but we have them all posted on our website, on our telehealth page. So I would encourage everyone to try to go and take a look at those guidance documents between now and the next time we meet, just to get a better sense of what the regulatory landscape is for Medicaid. And again, I don't know if anyone else from Medicaid is on and wants to chime in, but that's I'll stop there for now.
Anyone else from Medicaid want to weigh in? Okay, and is Joe Wynn from United Healthcare online or available to speak? Okay, so what I would ask, is there any other representative from a payer that hasn't had a chance to add comment here?
Hey, David, it's Joe. I don't know if you can hear me now. I had to use the touch phone control to try to unmute myself.
Yeah, no worries. We're good. Thank you for joining.
Yeah. You know, if you're asking for perspective, it's very similar to Carefirst, and also the United Health Group infrastructure won't let me use the Google Meets platform. So yeah, if there's an opportunity to have an alternate, that'd be great. You know, our data reflects many of the statements that were shared in terms of utilization. I don't have the data broken down into specific lines.
Okay. Very good. We appreciate that. If
detail.
Okay.
In terms of our, in terms of data, you know, using data to reach conclusions about the user experience, whether or not individuals actually like the experience, that I don't have. I'd only be speculating on that, but I do know that a large number of our members have taken advantage of telehealth during the pandemic. So that's what I have. I'm looking forward to learning more as well. Thanks for letting me speak.
Yeah, no, we're happy that you joined, and your comments are important to us. So you might find it interesting to get a perspective from AARP here. We have a representative from the community representing AARP. Jim, can you make a few comments?
Sure. First of all, AARP, like all of these other groups, definitely wants to see a continuation of telehealth services and reimbursement for them, and has gotten numerous comments from members that they've been these services have been tremendously valuable during the pandemic. The one concern, especially for the age group that AARP has, is many of our members are not as conversant with the technology, and that does make it a little bit harder for them, particularly on the visual side, and that's an area that will need some improvement.
Interesting. Okay. And Jennifer Whitten, are you online or able to talk? Okay. Okay. If there are no other comments here, we're going to travel along a bit, and the next item on the agenda is to talk a little bit about legislative plans that some of the stakeholders may have as it relates to telehealth during the upcoming session. We've heard a little bit that there's more analysis from some of you, but if we could get a general sense of if there are clear plans to introduce legislation, we would, and you're comfortable giving the group a heads up, even if it's absent too much detail, that would be great. So with that, let me open that up a little bit. And I think, Rebecca, I believe I saw a message here. Are you able to comment?
Sure. My message was just lauding Medicaid for quickly responding and for continuing to support us. But I think on the legislative front, we are focusing at the national level right now with the TREAT Act to look at waiving licensure during any state of emergency and providing a off period. It's the main bulk of the TREAT Act with some other goodies in there. But at a state level, I think we're waiting to see what's going to be put forth.
I see. So let's keep going around. From the payer's perspective, can anyone comment? And maybe I could just call out a few people. Matt, I think, why don't we start with you?
I think we are still evaluating a bunch of different proposals we have seen, and it's still September. We'd like to continue the discussion with the MIA and members of the committee, and I'm sure we'll have some ideas later this fall.
Okay. And our friends from Carefirst, Oleg or Deb?
Yeah, at this point, we have no plans to introduce any legislation on this topic.
Okay. How about Joe Wynn from United? And Joe may have dropped off. Okay.
Can you hear me all right?
We got you now. Go ahead.
Joe, you might be muted again.
Okay, is that better?
Yes.
Forgive me. I promise you I'm more technologically savvy than this. Similarly, we don't have plans to introduce anything on telehealth specifically during the 21 session to advocate for any of that, I should say. And we're here to learn more, and obviously we'll coordinate closely with the League of Life and Health Insurers of Maryland and with Matt's leadership, but nothing right now.
Okay. And our Ben from Medicaid?
I've got nothing that I know of on the legislative side. I think we'd have to check with someone from IRD or leadership to comment on legislation.
Okay, so let's turn to the provider side for a moment. I think I saw Ellen Weber. That may include some of the provider side. And if you can speak, you may be muted, but.
Hi, this is Ellen Weber. As many of you know, we appreciate the MHCC providing a copy of the Maryland Parity Coalition set of recommendations. I think those recommendations clearly reflect the broad range of interests that the signatories to that have. We've not put pen to paper on anything yet, but obviously there are many issues that are of utmost importance to us. As others have already identified, for behavioral health, the utilization of telehealth, particularly, I believe also with audio-only telehealth, has been significant and it's been very important. And obviously there are statutory limitations with regard to coverage of audio-only telehealth. And those are items that we will need to, I think, seriously consider in order to be able to adequately address the needs. We obviously realize that there are many individuals that do not have access to the telecommunication systems that are currently required under federal law, both particularly under Medicaid, and that those types of limitations are significant, particularly when we think about a potential second surge, when we are considering the timeline needed to widely disseminate a vaccine. So those are issues that are on the top of our list of concerns.
So Ellen, others may have questions. So there were 37 organizations that signed on to the letter that you have, but you had some very specific recommendations in the letter. perhaps I should just note them at a high level, and maybe you could talk about the thinking then from the representatives in terms of next steps, because the specific recommendations, just 3 of them here. Maryland should advocate for an extension of the exemption for the in-person examination requirements before initiating MAUD treatment and with controlled substance for MH conditions. Your thoughts?
Yes, so those are the prescribing requirements. Those are the prescribing requirements for controlled substances. Many of those are federal requirements, but it is a significant limitation on the ability of individuals to get both psychiatric medications as well as medications to treat opioid use disorders. So in our view, those are critically important to be able to modify those standards in order to ensure access to services and prompt access to services, particularly as we're seeing increases in the rates of opioid use disorder, overdose disorders. Right now, our state obviously has identified an increase in those overdose rates after things have begun to decline. There are increases in psychiatric conditions as well. And so members of our coalition have indicated that those types of flexibilities have been essential to be able to get access to care.
And the next item you mentioned was Maryland should advocate for continued flexibility in take-home doses of MAUD to reduce in-person encounters for patients who are deemed stable.
Yes, I mean, those relate to methadone, access to methadone as a take-home dose. As many of you are probably familiar, the federal requirements are particularly restrictive with regard to access to methadone and for treatment of substance use disorders, not for treatment of other medical conditions such as pain, but for treatment of substance use disorders. There are very strict requirements with regard to being present in clinics for initial dosing and requirements with regard to allowed medication that is allowed for take home after certain periods of time. The federal government has made those requirements far more flexible, again, on an individualized basis with regard to clinicians working with patients and determining which individuals may be more appropriate, obviously, for increased medication. And we believe that, again, is an essential, absolutely essential requirement in order to ensure safe access to care without putting patients, families, and providers at higher risk.
Yeah, and I think this dovetails to your very last recommendation, which was Maryland should reimburse for substance use disorder providers and programs to deliver methadone directly to patients to minimize the risk of transmitting COVID-19.
Correct. I mean, right now, some treatment programs are already doing this, and that comes at a great cost, obviously, to them. But it is a function of a very, very heavily regulated healthcare service, more heavily regulated than anything around. And again, as I've said, far more heavily regulated than when that same medication is used for treatment of pain. So very important, again, for patients who do not have access to their own transportation, who would be taking public transportation, who would be putting themselves and families at greater risk.
Okay, very good. Thank you. I think Deborah Steinberg, Nikki, were you able to capture that? Was making a comment?
Yes, so David, would it be now a good time to open it up? Jennifer Whitten had made a comment about updates from HHS as it relates to federal waivers becoming a long-term policy. So does anybody want to comment in terms of what was proposed for 2021 and if there are any implications that we should take into consideration for the state?
And is Jennifer able to speak, or?
I don't know if she's able to.
Yeah, I'm back. Thank you. Can you all hear me okay?
Hey, Jennifer.
The one time I had to step out, I think you called on me. My apologies. So my comment, so a couple of thoughts here. Appreciate the discussion. I guess for the record, the Maryland Hospital Association is working with our members to really identify a number of the priorities and flexibilities that they believe would be important post the pandemic. And so we're still working through that process. I think the next meeting will have more information to share in terms of both patient and provider experience. Hospitals have been using, different mechanisms of telehealth, both synchronous and asynchronous, for a number of years, but obviously the rapid use to mitigate exposure to COVID and making sure that patients can continue to have access to care was critical. So I think that there's really an equity angle to this, and we need to ensure that we continue to have access. So not in a place today to share some of our thoughts about legislative session, but know that we will be looking at a number of proposals and working through those priorities. My point on the federal side is we are also very focused on the federal reforms, and we know that HHS has made statements in terms of making permanent some of the federal flexibilities into their regulations to allow states to continue some of those flexibilities, but perhaps not all. And so, as we think about state policy, I think we also need to stay close to what HHS might be proposing and what opportunities that will allow the state, whether that's having Medicaid be able to adopt more flexible policies, whether that's having the state apply to a waiver that allows us to continue those flexibility as it relates to total cost of care and those opportunities. I think that that's important in terms of long-term priorities and opportunities for this work group in the state.
Yeah, that's a good point. Thank you, Jennifer, for participating and sharing that. Nikki, before we go back to the providers, and I do want to get to Kimberly Robinson, who joined us just a while ago, to her points in a few moments. But were there other comments, Nikki, that we should tee up here?
Well, Eric from the Alzheimer's Association has echoed the remarks Jim made from AARP in terms of what would adding the issue of knowing how to use the technology and access to the technology both in homes and in long-term care facilities. And others have made some other considerations, which, as I've just noted in the chat, I think we'll sort of highlight some more of these as we move on to the discussion grids, and we can flesh out some more of these areas in particular. But we have some comments coming in around audio only. And Helen Hughes, Dr. Hughes, just commented DC Medicaid has made permanent changes for allowing home as the originating site and audio only.
And then Robin.
And Robin, would you like to talk about this licensing issue?
Sure. Thank you. So we've got Sonia Lawson also on the line from the OT Association, but just wanted to highlight, I know licensure definitely is an issue in terms of providers being able to provide continuity of care and so forth across state lines. I think we'll see a number of different professions come forward with compact legislation. Many of them are actively looking at it. The occupational therapy profession is actively looking at it, has been working with the board, and there'll be a board discussion on this next month, and anticipate potential legislation this session. So that's just one piece of the licensure puzzle, but just wanted to flag that I think compacts are really important. They were actually specifically called out in the legislation this past session from Senator Kagan and Delegate Rosenberg, that the state should actively support compacts. And so just wanted to flag that. We'll probably be seeing a lot of those.
Okay, very good. Thank you. So before we go back to getting more of the provider perspective, let me just sort of bounce to Kimberly Robinson. Kimberly, are you able to communicate?
David, can you hear me?
Sure. Good afternoon.
Hi. Sorry to be joining late. I had a conflict, so I joined the call late. I think what's happening is folks are sharing if they have a specific legislative plan. Is that what we're doing?
That's correct.
Okay, well, my answer is probably going to sound very much like colleagues from my industry. And for those who don't know me, I'm Kimberly Robinson from Cigna. We do not have at this time a specific legislative plan. We are a member of the league, and so we have had some discussions, and certainly internally, we continually evaluate the role of telehealth throughout the very dramatic shift that we saw this year and the way that it has really stepped up to fill the gap. And so we are developing thoughts, but I don't have any specific proposals.
Okay, good enough. So let's turn back to the provider side for a moment. And Pam, I don't know if you're still able to make comment or if Susan or Jean has joined from the Medical Society. Let's give her a moment. Let's see.
Oh, sorry. Unmuting was a little bit. So I don't know that I have anything to add specifically. I do know that, I mean, Medicaid doesn't have any specific proposal right now or something that they know they're going to advance. Many of the principles that have been raised before, either through the Parity Coalition, we've been talking with MHA, and we're going to be talking with our members. Medicaid on the physician side, on the Medicaid side of things, has their House of Delegates meeting in about a month where there'll be a little more detail on what their advocacy agenda is. But they will undoubtedly be joining most of the others who have already talked before me about addressing some of these issues to ensure that those flexibilities and benefits continue forward even post public health emergency, given what we've learned about how they've improved access and efficiency and effectiveness and those kinds of things.
Wonderful, thank you. And from the pharmacist perspective, we've heard a little bit. Does anyone from the Pharmacy Association or representing pharmacy wish to speak at this point? Okay, we may have lost them, so we'll come back. So we've touched on a number of the provider groups. Dan from the Behavioral Health Care Coalition, can you weigh in here?
Yeah, hey David, thank you very much. I'll just echo what some of our, my colleagues have said. The Behavioral Health Care Coalition, a number of our members signed on to the recommendations that Ellen Weber was going over from the Parity 10 Coalition. And we're working with the Parity Coalition and working within the Behavioral Health Coalition to kind of determine next steps legislative-wise. We don't have anything, any concrete legislative proposals right now, but we'll continue to work with our partners and with Mhcc and others moving forward.
Very good. Sally Ann, are you still online with us? Okay, she may have dropped off. So did we capture from the provider's perspective all the different provider groups here, or have we missed anyone? Okay, I'll take that as we haven't missed anyone. Is there any more views from anyone here on the call this afternoon relating to potential legislation? Okay, so let us move into the next level of discussion this afternoon.
Before we leave this area, David, maybe we ought to mention the national proposed rulemaking on the physician fee schedule. That there were some rather significant items that CMS proposes to make permanent that were first allowed during the public health emergency. But I think it's probably noteworthy that they are not proposing to continue much of what was temporarily authorized under audio-only telehealth services, but do seek public comment on that. I think folks from Hopkins talked about that. I think there's potentially a fertile area for discussion at both the national and the state level, particularly as it relates to some behavioral health services, where Ellen and others have talked about the benefits of audio only, even when both audio and visual are not available, that I think warrant us paying attention to.
So that's a great point, Ben. Thank you. And there's a couple other points. Nikki will let you call them up in a moment, but I do want to give
David, this is Ellen Weber. Can I raise one question, one more issue?
Sure, go ahead.
Thank you, I appreciate it. And this relates to the audio only. And I just posted something in the chat with regard to this really important issue with regard to the CMS's position with regard to audio-only telehealth. And I know this is something that Ben mentioned, and we have had conversations with CMS to address this very point, and have learned that CMS has no statutory or regulatory standards with regard to audio-only telehealth. And what their position has been is that is a state issue only. Many states defer to the Medicare standard, and Medicare on the federal side does have some very, very specific standards with regard to audio only. But with regard to CMS Medicaid's position, they see it as a mode of service delivery. It is not a separate service. And so it really does rely on states to make their own determinations as to whether or not they're going to deliver services audio only. They are available for a federal match. And again, under Maryland law, there certainly needs to be some statutory modifications in order to recognize audio-only telephonic services as a telehealth service. But that's a legislative policy matter. It is not a matter, as we understand it, of what CMS would approve.
So this is Trisha Roddy. I'll just comment on that. I think we've gotten a bit of different direction from CMS on that issue. We've asked them to see what their path forward is for approval for states. They responded back saying they don't have a path forward quite yet, but they are looking into this to see if there will be guidance on this. Again, as Medicare covers audio only, there's separate codes and different reimbursement levels. What is happening during the pandemic and during the state of emergency, and what we have a special approval from CMS right now is to pay for audio only as it would be like an in-person visit. So I think the key words are like an in-person visit. And again, we are looking for CMS approval. I know, Ellen, you've sent us some states that have put together legislative proposals. I have reached out to a couple of them. They do not have a path forward yet to figure out how they're going to get federal match on that. So again, I think there are, again, some policies and a way that at least Medicare has covered audio only, but again, it's different codes and different reimbursement levels. So we'll continue to have that conversation with this group and other stakeholders, but again, we've gotten a bit different feedback.
Tricia, thank you for that information. So Nikki, you've received along the same thought a handful of comments. Can you just go through them for the group?
Yeah, sure. So Rebecca had asked, what is the HSCRC stance on allowable services post-pandemic? And is it tied to the national public health emergency or state level? And any opposition to talk about permanency?
Yeah, so before you start, let's see if there's someone from Tequila, Terry, or anyone else from the HSCRC.
Tequila had to hop off, but this is Erin Sherman. Would you mind repeating that question one more time for me, just because I missed part of it?
No worries.
Sure. So the question was, what is HSCRC's stance on allowable services post-pandemic, and whether it will be tied to the national or state public health emergency?
So essentially where we are is, we're evaluating the potential for a federal waiver request based on the stakeholder innovation group waiver request stakeholder idea, but there's no ETA on that, and we're still reviewing requests that are coming in on that. And does that answer the question?
I think it provides some guidance.
Yeah.
Provides some guidance.
Yeah. And would that waiver, so let's say we did a federal waiver based on the stakeholder waiver, would that make it permanent? So facility fees via telemedicine, is that what we're looking for?
I'd have to look more at look closer again at the request. I mean, it's sort of in, early phases, and there's still conversations that are happening about what, stakeholders want it to look like. So there's not a lot of detail around it. It's still very early in the process of being considered.
Thank you.
Jennifer Thomas is unable to unmute. We're reaching out to you to get you some technical assistance, but we acknowledge that your comment around pharmacists and how they're certainly engaged in telehealth, as Dr. Brandt had pointed out earlier, and how the Maryland Pharmacists Association is interested in pharmacists being included as providers for these services in the future. Rebecca commented how Maryland telehealth definitions carve out telephone from telemedicine modalities, and CMS has invited comments on audio only in its proposed 2021 physician fee schedule. And so she encourages everyone to comment strongly because they're due next week. And then Deborah Steinberg has commented, I believe CMS Medicaid doesn't have guidance because there is no need for an SBA or other CMS approval for states to get a federal match for audio only. It's a service delivery model, not a new service under Medicaid. The Medicare definition and standards are different, but nothing in federal law or regulation requires Medicaid to use the Medicare definition or standards, which is why DC, Colorado have been able to make audio only permanent through legislation.
Reactions to anything that Nikki mentioned from anyone else on the line?
So, I mean, this is Trisha Ratty again. I mean, I think the comments around the audio only, we'll disagree at this point. We have reached out to DC, Colorado. They have state legislation that authorizes it. They do not yet have federal approval in order to get a federal match on the service. So again, we'll continue to have this conversation with the stakeholders, but obviously we did need to get authority from CMS because we have disaster spas, 1135 requirements that allow us to pay again, like an in-person service at the same reimbursement level. So again, we'll continue to have this, but we are having conversations with CMS and we'll report back to you.
Okay, just to, I skimmed over the comment, New Hampshire as well. So those 3 states have made audio.
I think Trisha covered, this is Ben, Trisha just has covered this, but I just wanted, I know that I'm not familiar with where the process is in those other states, but I know in DC they published a final rule notice on their website last month, I believe it was, in which they stated that they don't currently have the authority to pursue a path forward for audio only. They issued that as a recommendation to CMS, but at this point they don't have that document says that they don't have the ability to do it on a permanent basis. So I know that's been published by DC Medicaid. And also I would just reaffirm that as far as the codes that we're billing now, that are being billed for audio only now for Medicaid, we are paying those codes as the regular E&M evaluation codes, which are the same codes that are being billed for in-person services. So those codes, as written by the AMA, CPT codes written by the AMA and then adopted, right? And those codes are for face-to-face services. And that, right, currently they're being allowed for audio only. But if we were to look at audio only on a more permanent basis, as Tricia mentioned, it would be different CPT codes that we'd be looking at, and that would be a programmatic change. So I just want to make sure that's clear.
David, one suggestion. I know we have some of our colleagues from the MIA are on the line. I thought we should give them a chance to offer their thoughts. David Cooney, among others, have been active in this area, so perhaps they have some thoughts, not narrowly on audio only, but on the broader issue of the expansion in the public health emergency.
That's a great point. Thank you, Ben, for bringing that to our attention. David Cooney, can you unmute, or are you able to comment here?
Sure. Thank you, David. Yes, we've certainly been monitoring this during the pandemic and have been in pretty much constant communication with the carriers, especially during the early months on issues such as this. We've really been looking at, what Maryland law currently requires in the commercial market, and then the voluntary accommodations that carriers have made to go beyond that. So we're not on our end, sponsoring any legislation or anything on this, but we're certainly going to be around to provide technical feedback on what would need to change in existing law to make some of the accommodations permanent. I think one thing to bring up is that the current law is based on language of what's medically appropriate. And we can make that kind of determination on a case-by-case basis if we get complaints. And the idea of what is medically appropriate for telehealth certainly changed during the pandemic. But there has been prior legislation that has pulled out certain particular types of services, particularly with mental and behavioral health, to kind of spell that out in the law that, this is medically appropriate. So it kind of takes that out of the case-by-case determination. And I think we're looking at, too, as a lot of other people have mentioned, just how the federal law will interact with state law, particularly with the types of platforms and everything that are acceptable for telehealth and coverage of the audio-only visits, which is, not currently covered. But we don't really have anything, I think, additional to add right now at this point than of all the other things that we've heard so far on this call.
Thank you, David, for that information. But I think we're at a timely point on this topic. So before we move away from it, I would like to invite some of the private payers to weigh in on their thinking in general about audio only as a covered service. And Deb or Oleg, are you able to unmute and participate here from Carefirst?
Yeah, it's Debbie. So you're not. I'm going to say basically the same thing we have, David. We're not prepared at this time to really give any more information than what we are currently doing. We're talking about it internally, but it's too early for us to give you any public statement at all.
Understood. Thank you. Matt from the League of Life.
Thanks, David. Yeah, I don't know if we're prepared to give you any kind of thoughts on this just yet. I think that we're still sort of trying to deal with what's in front of us, and I'm not sure that any of the carriers that I've spoken with yet are prepared to even, or they're not even in a place to evaluate what the impact of COVID-19 has been and how we even shift back to a post-COVID-19 world yet. So I don't know if I have anything that would be substantial for you at this time.
So anyone from the other, Joe from United, is this pretty consistent? And then Kimberly, I think, looking to what Matt said, pretty consistent.
This is Kimberly. My answer to that is yes. That would be consistent. It's something that we're certainly looking at, but I don't have anything to share at the moment.
Okay. So to some extent, is legislation like this too soon? Meaning that is this something that if the pandemic were to continue well into next year, you'd be thinking about more as legislation, not in the upcoming session, but in the following one? I feel like on audio, that's about what we're beginning to hear, particularly as it relates to more guidance from the federal government or programs like Medicaid, by way of example. Any reaction?
Hi, David. This is Dan Shattuck. I don't know if you can hear me.
We can.
I just want to, I guess, comment. I think listening to everything to this point, what's resonating for me, and I know what resonates for our clients, is ultimately the need for some consistency and transparency as it relates to who can do what, how are the services going to be paid for. And I know there's a lot that needs to be sorted out from the federal level to the state with Medicaid, the commercial payers, what falls under the purview of the MIA and what doesn't. So there's a lot, but I think there is room for change and there is room for legislation this year, even if it's just baby steps to clarify, okay, these providers can continue to do telehealth in these circumstances. And I think ultimately what I'd like to see from this group is to move to that point where there's that uniformity or that clarity across all providers, physicians, non-physicians, and so forth, that telehealth truly is just another service that can be applied and reimbursed for, and it's the benefits to the patients and the providers are evident. So that's just my thoughts.
So I think, Dan, you make a good point, and to some extent that transitions us to the next agenda item quite nicely. Before we go there, does anyone else have any final thoughts before we continue to press ahead with the agenda items?
David, this is Jen Witten. Just one thought here is appreciate the conversations we've had so far. We've spent a lot of time on audio only. You know, there's several other, I think, areas that are just as important in terms of thinking of originating site, ensuring that we're using synchronous and asynchronous technology to the extent that it's appropriate, making sure that we're providing the HIPAA protections as we use different modalities. And so I just would say that we need to be flexible in our approach and allow for some clinical discretion. We hear that loud and clear from our members, both to use these tools as inpatient tools and outpatient tools, that having flexibility. And so what I would not like to see is us create additional barriers on which providers and which conditions are appropriate. I think we need to just think about some consistency across the board. So I don't want us to just focus on audio only. And maybe that leads into the next section of what you're proposing for the work group. But there are other things to think about in this space. And I just want to also acknowledge Medicaid has been very open to working with the providers around definitions of originating space, and know that they've been doing some work there. So I think that that's an important area to focus on as well.
Yeah, good point. Thank you, Jennifer, for reminding everyone that this is a fairly big area and lots to talk about. So let's just take a look at the discussion items, if we could. So Ava, can you bring them up? And I want to kind of give a little bit of overview about what you're looking at. Some of you who have worked on work groups here with the MHCC staff, this isn't unfamiliar to you, but many of you're seeing it for the first time. We have assembled about 10 different categories of areas where we think we want to get more information from the work group. Where there's synergies, and there are clear synergies from the work group, then we may not need to spend any time talking about them. But what we'd like to do with the remaining time we have left today, which is about a half hour-ish, is to talk about these. But what I'd like to do before we actually dig into the detail, which we'll talk about the structure in a few moments, is just cover the topics. And I'd be interested to get a sense if there's where there's synergies in the topic area as opposed to the detail that we'll talk about. So let me just sort of scroll through the list and call them out. And then if you think these are areas where as a stakeholder you would say, yeah, we support, please weigh in here, and we'll just pause and everyone knows what stakeholder group they represent. And if you can just weigh in, that would be great. So the first category.
David, excuse me, what does support mean? Support discussing this topic or support the actual statement that's in the gray box?
So what we would say is support. So you could take that many ways. That's Debbie? Is that?
Yes.
So it could be taken many ways. What we would like to present it as is meaning that it's not an official, it doesn't have to be an official statement from you as a stakeholder, but it's in concept as a stakeholder, you would support this is general legislation or policy. Maybe we think of it as policy because it could be where a policy is adopted and legislation isn't needed in all instances. But let's go that approach first, and then we'll come back to the details.
David, I think I would say let's cast it a little bit wider because I think there might be benefit from viewing these discussion items as areas that we wouldn't insist that you support it, but think it's worth discussing in the context of this work group rather than brushing it aside either as too soon or this is never going to happen or this is an automatic, this has got to pass. That this is a safe space, I think, to open up and discuss some of these and hear everyone's perspective on it too, if that's okay with you.
Yeah, no, well put. So with that, please keep that context in mind. And we understand that some of you can't see the materials, so indulge me as I read them for you. The first one is removing telehealth restrictions on originating sites, provider types, and conditions that can be treated. Reactions? And I'll just open that up widely.
Yes, from Hopkins.
Okay, thank you.
David, this is Jen from MHA. We would say yes, but I think having originating sites, provider types, and conditions is a lot for one bucket. So just something to think about because, different policies impact those three different areas.
Yeah, that's true. It could be a lot to take on in one group, but we can tease that out as we go through the discussion. From other perspectives, from the payers, Deb, you had raised a question. Maybe we answered it.
This is really difficult. I agree with what Jen just. Can you hear me?
Yes.
I agree with what Jen just said. There's a lot to unpack here, and there might be some things we would be able to agree to conceptually, but it's just too much. And what my biggest fear, David, to be totally candid, is nobody knows what this means right now until we get to the details of it. So from a high level, it may be right until we start focusing in on stuff, and then all of a sudden you're going to have people retreating to different positions. And so it's hard to give a statement right now. I really apologize, but I feel sort of backed in a corner and don't know where to go.
And I think, I want to reemphasize that we're not insisting that there's you support it. I think the point that Jennifer made is really a good one, that this probably breaks into 3 or 4 areas, but that's helpful in itself. I mean, we want to get through the 10 items today. Some of these hopefully either can be moved off as either, not the time right now, or is going to be largely a federal issue, and therefore we shouldn't consider it or perhaps some of the reasons.
Yeah, and I think,
sorry.
Ben, before you weigh in, I think we're hearing the need to separate out the categories within this item, and we'll do that as we get through the discussion level. Ben Wolf, please.
Just a broad suggestion. I mean, I think separating some of these things out would make sense, but I just want to make sure that we're operating by sort of identifying the problem before we proceed to solutions. So removing telehealth restrictions from originating sites, provider types. And I think first we would need to identify what are the originating sites that are restricted, what are the provider types, and what are these conditions that are, where are the restrictions that we're trying, what problem are we trying to solve? What are the restrictions that we are trying to alleviate? Because I know on the Medicaid side, I mean, there are limitations program by program as to, some of that is based on federal guidance as to what codes are allowable and what codes are not temporarily and on a more permanent basis. But I mean, if you ask me to name a condition that can't be treated by telehealth, I don't know. I can't think of one. There probably is one, but that's not really how we come at it. It's not diagnosis code based. It's based on service and care delivery. So what's the problem we're trying to solve, and where are the limitations? And then we can sort of get into more of what changes should we be looking at.
So so Ben, you bring up a good point. The way we've approached the 4 quadrants is to tease that out a bit in the column or block 2, where we, what are the benefits, and then what are essentially the problems or barriers or unintended consequences. We try to cluster, because what we don't want to do is tease it too far, because we could spend all day and literally on one item. So we try to do a little bit of clustering, but you bring to light a very good point. So, and Ben has some inside knowledge because he's worked on some work groups with us in the past. So I appreciate you bringing that to light. So let's go on to the next one and just give everyone a sense of what that looks like.
Hey, this is Ellen Weber. If I could just make one comment about the previous one.
Sure, we'll back up.
Sure. The recommendations that you referenced earlier cover several of these issues as well. And I think it's in line with what Ben was identifying. We've identified where there are some specific limitations that we think could benefit from flexibility modification. And so it is, our recommendations provide some targeted guidance on provider types as well as originating sites.
Yes, very good. And we're going to, as Ben noted, and our executive director as well as Ben Wolf, we're going to separate these into categories. We'll take number 1 and split it into 4 different groups for the next meeting. So let's go on to the item 2. And item 2 reads, establishing a provider and patient relationship via telehealth when the appropriate standard of care is met, requiring in-person visits if a provider determines telehealth is not clinically appropriate. So let's go back to what our executive director said in terms of thinking about what we have here, and does this make sense, what we have here, based upon how it was sort of framed up?
I think definitely leaving it to the clinician's clinical judgment is important. This is Rebecca from Hopkins. We would support this. The word requiring is interesting.
Interesting meaning that it seems foreign, or interesting that it
like how do you have a requirement around this space? So typically what happens is a provider sees the patient virtually and says, you know what, I really need to see you. Come on in, let's make time, right? That's not a requirement. It's what's clinically appropriate for that patient. So I just don't know how do we enforce that requiring.
Yeah, so I think you're suggesting we may want to tinker with the wording a bit.
Yes, please.
The thinking here would be, as a part of the standard of care, that's what requiring is building upon. But I hear you. I think some modification is certainly fine. Other reactions here?
So, David, there was legislation that passed during the last General Assembly that was getting to some of this issue, and I'll invite my colleague Robin Elliott to speak after I do. But the legislation did outline some of these requirements, and I think the language as it relates to encouraging in-person is that a provider must offer in-person visit if the patient prefers that or it is not clinically appropriate. So to Rebecca's point, you can't force an individual to come in for their appointment, but if identified that it's not appropriate to deliver services via telehealth, you should be able to to offer that as an alternative. And so I would offer that as an adjustment in this area, but think that there are already current state policies that set these standards.
Yeah, so for that second portion, Jennifer, you bring to light a good point. I think what we can do when we get here, and Robin will welcome your thoughts in a moment, but maybe we just amend it to either take this from the semicolon out and just work from the first part, or we modify it based upon what already exists. Robin?
David, so what I'm not clear on is this is modified actually already the law. And that just passed this past session, which did say that providers can use telehealth when clinically appropriate, and clarified that the telehealth isn't restricted to just synchronous, it could be asynchronous if clinically appropriate. So that was passed by a very wide margin. And so I guess I would just raise here, what is the goal of delving into this issue when it was just delved into this past?
Yeah, so there may not be a need to. I mean, if we think the existing legislation is robust, then we don't want to go in search of a problem. Or so I think if we all go, this seems to be adequate, then we just move on. So that's being modified. Ava's adding that to the statement below.
Yeah, and I think that's a good point, that as we go, we want to go through these kind of rapid fire in the remaining 20 minutes, and there are 10 of them. So if we can cast things out that, as I said, at the outset, that either are a bridge too far, overreach, or have already been resolved, or there's consensus that this is a strictly federal item, I think that's important to winnow this lips down to a more manageable subset.
Okay.
Regardless of whether you come out on one way or another just yet.
Okay. Thank you, Ben. Thank you, Robin. So number 3, Ava, you want to scroll forward? Permitting audio only when the treating provider determines it to be safe, effective, and appropriate. I think we can push through this. We've heard comment from everyone about that, and we realize there's more guidance that we need to get from the federal government before a determination here can be made. So Ava, I'm going to let us keep moving on to number 4. The next one is expanding asynchronous telehealth communications at the discretion of the treating provider.
David?
Yes.
Sorry, David, this is
number 3.
Jennifer, you broke up a little bit?
actually somebody else is on the line is trying to speak, so I'll let them speak first.
Okay.
It's Debbie. Sorry, it's Debbie.
Go ahead.
It goes beyond. The reason why we need to wait on this, I just want to add one more thing. It's not just what's happening with the federal government, but it's pretty new. To be honest, look, audio treatment is pretty new, and I think we also should be waiting to see what's happened. We don't really know until we analyze the data from as the companies and even for the providers themselves, what the quality is or isn't, and what we should do, if anything, with audio calls. So there's a lot we need to wait on than just what the federal government's going to do. So yeah. I just wanted to put that out there.
I think that's true, but would there be enough data? I mean, I don't want us to get off topic. Our executive director will be kicking me from a long distance away, but will there be enough data if the pandemic or state of emergency ends in the next 3 to 6 months? Would that data exist to make that sort of determination?
I don't know, right? But we got to look at it, and we're also going to see data from around the country and different things that are happening. But I don't. When you have something new like this, I do think we need to look at all sides and see what works instead of just making a global statement to move forward with something. We don't know what the effect is. We don't know if there should be guardrails around it. We just don't know yet until we really sit down and think about it. And so I just asked that. That's just something else. Wanted to add that to, besides waiting for the federal government to make a decision. I think there's other data points that we need to think about.
Yeah, fair enough. And when we come back to this, we'll wanna dig into those points a bit more.
I think this is one of the central issues, and I don't know where our commission would come out on this. I've heard some of the surgeons surprise me and advocate for audio only when I've been pretty skeptical. I think this is a service by service issue in underutilized services, underutilized treatment like behavioral health. I think that some may feel differently than cardiac care by comparison. And I wouldn't necessarily say it's right for action, but it's something that we ought to talk about and really kind of rotate the issue to think about this. The dirty little secret is in out of self-pay behavioral health. There's probably a hell of a lot of audio-only behavioral health that's going on today. That for those that lack the means up until the pandemic, did not have the benefit from. I also take note of something in behavioral health that I kind of chuckled about, which was in the NCQA Connected Care Symposium that just completed earlier this month. They talked about the dairy farmers from Wisconsin willing to consider telebehavioral health from their barn. I guess the cows did not talk a lot, but being very, very hesitant to go to a building labeled, behavioral health clinic, and sort of buttressing my point that we really do need to think about is telehealth going to enhance and increase access to care, or is it going to induce excessive utilization? We may not be ready for this, but I think this is really important.
Yeah, thanks for that. Jen?
Yeah, I just need to say this, that this is an area of importance to hospital providers. Agree that we need to really monitor this closely, and we need to think about services that are appropriately delivered audio only. But I will tell you that without this mechanism, there were thousands of patients that would not have been connected to healthcare services during the pandemic and would have been forced to come into clinics and expose themselves potentially to COVID. In addition, I think it's important that we monitor what's happening at the federal level and appreciate the potential impact to a state budget. But I would not, I think by waiting for federal action, we are going to find ourselves really limiting and cutting off services for again, many individuals who've had continuation of care via audio. And this isn't just about rural areas. This is also about individuals accessing services in urban areas. We have data showing in Prince George's County and Baltimore City where this was fairly significant. So I would suggest that we continue down this path to better understand. And again, MHA will have more data in terms of some of the utilization and patient experience in this space.
So this is going to be an area for a lot of discussion. Matt, if you wish to, why don't you make the last point and we'll continue on, and know that we'll come back to this.
Yeah, thanks, David. I think, I guess my comment is more for overarching than this particular slide, but like we said before, this is still an ongoing and very fluid situation. And I don't think anyone would suggest that the state of emergency is going to be lifted in the next couple of weeks. I think we are sort of in the long haul for this. And I don't think that anybody is going to stop continuing their adaptation to address the public health crisis that's in front of us. And, as from the carrier perspective, I think we need to wait, be data-driven, and not rush into a reactive policy that might have unintended consequences down the road that we might have to come revisit. So my my inclination is to take a measured approach to all of these policy changes and come up with something that we all agree is the best fit for the time. And that is obviously going to take a while, and each one of these slides we could spend 2 or 3 hours on alone, and I'm sure we're going to, but that's just my 2 cents for now.
Thank you, Matt. So let's cover, we have about 10 minutes before we wrap up. Let's try to get through the remaining just so we can give everyone a sense of what we're looking at in front of us. The 4th item is expanding asynchronous telehealth communication at the discretion of the treating provider. Reactions, comments? Rob, go ahead. I think Rebecca, it looks like, I think I can see you're going to make a point. Okay. Robin, Elliott, thank you, Rebecca.
Yes, I'll just add that this is allowed under Maryland law when clinically appropriate. One of the major barriers continues to be reimbursement. And the other thought I would offer is it's really important to consider the preferences of the consumer, not just the provider. Obviously, it has to be clinically appropriate, but we've got some feedback that for some consumers, this is their preferred way of interacting with their providers for certain types of conditions. And so that's really important.
And maybe we could add up top, Ava, so treating providers and consumers. And then perhaps David, there's David Cooney from the MIA. There's not a lot of time left to weigh in, but if you could note to self that we want to get your thoughts here, that would be great. Any other reactions about this before we move on? Okay, let's travel along. Number 5, allowing a treating provider to use modalities, for example, real-time video conferencing, stored forward, remote patient monitoring, etc., that meets the appropriate standard of care and improve access to care. Any thoughts here?
What are we trying to solve here? I think this is already allowable, or is it uneven across roles of providers?
So it's our understanding that it's the evenness approach here. The concern has been that it is uneven.
So David, in this case, I think, again, allowing some flexibility on being able to identify the appropriate telehealth tool to deliver care. I think what you may be alluding to is that there are different policies, both I think on the state side and perhaps with private payers, that reimburse and recognize some of these modalities.
Yes.
And know that Medicaid has, in particular, made a lot of changes to the use and reimbursement for some of these modalities, but does not encompass, or should I say, has certain restrictions on when using those modalities.
Yes, good point. Thank you for adding some additional clarity here.
David?
Yes.
This is Kimberly from Cigna. On this one, sort of, again, echoing Jen's point, she made it on this slide as well. You've collapsed a lot of things there, and I will say that I do believe that my medical directors do kind of distinguish remote patient monitoring from other telehealth. And so that's a pretty big collapse to pull that in the same breath with video conferencing and so forth, and some of the more standing in for other ways that treatment is happening. So there may be another conversation to be had there as well.
Yeah, we'll make a note. Thank you, Kimberly, to tease out, to look at separating some of the items out of number 5.
Just to add to, sorry, just to affirm what Kimberly said, just point of information for everybody. Medicaid's remote patient monitoring program is actually a separate chapter of regulations from the telehealth, the synchronous audio video telehealth. So they're actually in 2 different parts of COMAR. So that would, separating them out would make things easier from a regulatory perspective as well.
Agreed. We will note to the team that will take this on. I think Pam, you were going to make a comment.
I think the only other question that needs to be evaluated, and some of this may apply to the other screens as well, is there is a question on all of these whether there are different authorities allowed under licensure boards that extend beyond the state of emergency or not, that isn't tied to insurers or clinical appropriateness, but maybe regulatory issues for different types of providers. I don't know if there is or isn't, because that's been such a movable or fluid issue over the last year or two, but I suspect we're going to need to look at licensure issues throughout this whole conversation.
Yeah, I think so. Let's call that out, Ava, as a bullet point here. It's licensure issues. I think we want to note that in the parking lot item, so we can take that away. So let's travel along a bit more. We'll allow Ava to scroll up. Item 6, insurers offering telehealth technology such as smartphones and tablets to providers and patients to support care delivery. Reactions? Matt?
There's going to be some concerns about how this would be administered from the carrier's perspective. I don't have any specific recommendations at this time.
Okay, and this is another area where insight from David Cooney will come back to you. Hopefully you can give this a little bit of thought.
Hey, David,
yes.
This is Deb. Where did this come from that carriers would be offering smartphones and tablets? What is this from another state? Is this from,
So,
I don't know where it's coming from, so I'm just curious.
So what you see here is a conglomeration of ideas that have come from providers, come from consumers, come from payers. It's an array of, it's just a catch-all of things that we've collected since the state of the emergency was enacted.
So, okay, so let me just give you some food for thought on this one, since I've never seen it really before, or thought about it. But from an insurer point of view, the average time a member stays with us is a very small period of time, and in some cases it's less than a year. And so this, I just want to throw that out. We'd be offering to provide somebody with a piece of hardware that they aren't necessarily going to stay with us. You know, you have the right to go to any carrier at any time, especially once a year. So I don't know how feasible this is.
Yeah, no, fair enough. We'll note that and come back to it. Maybe maybe that concept is amended, because I think you're talking about consumer/patients, but maybe the element of providers is still something that's worth talking about. Okay, Ellen.
David, thank you. I mean, one question that we have is, I think one of the points you're hitting on, though, is sort of access to technology. I know MHCC has paid a lot of attention to that, has tried to address some of those digital divide questions. I don't recall what is on the rest of your list, but those are issues that I think we need to address. Would hopefully be able to do that through this.
Understood. We'll add that.
And it goes again beyond just those audiovisual technologies. I mean, you know, consumers, lower income consumers are facing needs for just minutes on their telephones because they can't access services without additional minutes on their phones. So wanted to just broaden that out just also a little bit.
So we'll add technology here as an item.
And David, this is Kimberly. I completely understand exactly what Ellen is saying. In a world outside of my real life, dealing with digital divide issues in the education space is something I've been doing, right? I do struggle a little bit with this one that is specifically drafted to pin the responsibility on addressing the technology shortfall on carriers. That's really in many ways kind of far afield of the role of the carriers and what we're built to do, what our resourcing is. And so I think it's one thing to make the conversation around the technology. It's another thing to make the launch place from what will carriers be expected to do about it. I think that's a much more narrow way to come at what is a much bigger issue.
Yeah, and I agree. And I think that the thinking here was more of permitting versus requiring.
David, can I also offer, perhaps maybe to Kimberly's point, this is Jennifer Witten, maybe a broader perspective here is that I wonder, if it's worth really looking at whether or not the state, and the stakeholders are fully leveraging opportunities to purchase technology and share with individuals. So for example, the FCC had a number of grants during the pandemic that did allow purchasing devices. And I know that some of our hospital members, in particular, Peninsula Regional, who worked with the immigrant community on the shore, this was a concern for them. So maybe it's a bit of a broader scope than just looking at what the carriers provide.
Understood. Yes, understood. So let me just sort of show you what's ahead, and we won't pause unless there's something that we need to stop. We have about 3 minutes left. I want to be very mindful of your all's time. Ava, can you scroll ahead? And unless there's, I'll just read number 7, allowing providers without a Maryland license to establish or maintain a treatment relationship with patients located in Maryland and using telehealth as long as the appropriate standard of care is met. I believe I've heard people say this is an area for discussion around licensing, so I don't know that we need to necessarily pause here. Let's go on to 8. The next one is developing a patient telehealth bill of rights that overviews the standard of care, privacy and security, and patient responsibilities, among other things, that would be provided to the patient before an initial telehealth encounter.
So David, this is another space where there are already policies, and I can't point to them right now, where there's requirements in terms of what's disclosed to a patient prior to a telehealth encounter and what must be captured in terms of patient consent. So I think creating duplicate documents is very cumbersome, just thinking of the modality. So I would encourage us to look at current state and federal rules before creating another pathway.
Yeah. It's also in the licensing board of just to give you an example of the Maryland Board of Physicians. This was intended to be an expansion of what exists as opposed to, in addition, something separate.
And David, this is Robin, and I can follow up with details later. I know we're short on time, but part of the Kagan-Rosenberg bill was actually to create standard consent language across all licensure boards. So it allows for written and oral consent. And I agree with Jen, and having very elaborate separate documentation may not really increase consumer awareness or information. Oral consent may be just as effective.
Agreed. We'll need to look at that, but this wasn't contemplated as being separated from what exists, more of an addition to. So we'll come back to this. Let's go on to 9.
David, real quick, just on number 7, I want to throw out one other perspective. In addition to the concept about the Maryland physician treating out-of-state patients, well, no, I want to make sure that's added. So if you're a Maryland provider and your patient might live in Delaware or DC, how do you maintain that consistency and that continuity of care? So I want to throw that in there, number 7.
Okay, good point. Thank you, Dan. So let's go on to number 9. Reducing or waiving cost sharing for telehealth services through the end of the public health emergency or December 31st, 2021, whichever occurs first. Okay, let's take a look at number 10. The last one, reinstating HIPAA technology standards that were relaxed by OCR during the public health emergency. I think this was covered in the slide deck that Nikki reviewed early on, but we've heard a lot of comments about the relaxation of the federal requirements from HHS are a bit too far, and that there's concerns around privacy and security. And interesting enough, this has been driven by the providers as opposed to anyone else. So it is something that we'll probably want to talk a bit more about. So with that, we're over by a minute. Give us, if you'll all will indulge us, just 3 more minutes or less. Let us tell you about next steps. Ava, if you could talk about when the next meeting we've tentatively scheduled for, and I would ask you to use your football field voice. We had a little trouble hearing you at the beginning.
Sure. So as far as next steps, I'll be sending out a meeting summary next meeting and the recording.
Ava, we're losing you. So Nikki, can you step in?
Sure. Ava was just mentioning how she will be sending out a meeting summary before the next meeting, which is scheduled to occur on October 21st from 1 to 3 p.m. She'll be in touch with the calendar invitation and meeting materials, as well as a recording of today's meeting. We want to thank you again, and Deb, we note your concern around using Google Meets going forward, so we will try to address that in future meetings, and we appreciate everyone hanging in there for 2 hours. We anticipate a meeting through the end, meetings a month in November and December through the end of this year, so stay tuned for more information, but the October 21st meeting will be hitting your calendar soon. And I personally will be going out on maternity leave in another week, so I know Ava and Justine will be helpful in responding to any comments and concerns you have, and sending the information out to you in advance. So thanks for hanging in there with us for a couple extra minutes, and we look forward to continuing the dialogue next month.
And before you go, we're going to give everyone a little bit of a homework assignment. So when it comes to these, what we're calling these discussion items or this grid, so stay tuned. That'll be in the email. Whatever information we can get before the next meeting just moves us along faster. And our commitment is 3 meetings on this. So we want to try to keep true to our word as best we can. Thank you all. Back to our executive director. I think, Ben, if you're still there, final remarks. And Ben may have had to sign off. He's pretty punctual on that time. So with that, I'll just say once again, thanks everyone. It was a great first meeting. Hopefully we've intrigued you enough to come back for meeting 2 and 3. Have a great evening. And again, thanks for your time today. Be well, everybody. See you.